anyway. Thank you for remembering the recording. If you wouldn't mind sharing the screen so we can kick this off. It's a jam-packed schedule we have today. All right, first off, we had a bit of a change in our a team here. So John Kelly and Brandon Bergman are no longer part of the steering committee, though of course they're still rooting for recovery science as always. Recovery Research Institute is always still your resource for any of those sciences. But our website has changed. So now any kind of links that are related to this particular project are going to be at the Healthful Flourishing program, which I'm leading, and I'm going to be continuing to lead this program here as well. So we'll put some links in the chat for you so you can find those places. Next slide. Since I think, here we go. Just a reminder, if you do want closed captions, Zoom has great closed captions. And here are some directions for how you use them. And it's also on the slides you can download, so we can send you a slide as well. Next slide, please. Here we go. So here's our switched up team that we are changing, mostly staying the same. Dr. John Kelly and Dr. Brandon Bergman are not on this slide anymore, as I mentioned, but John Picard, who also is one of our presenters and you have known from another seminar from Faces and Voices, is joining us on the steering committee for all of our R24 related activities. All right, moving on. And John, I'll give you a chance to talk later because you're presenting for the pilot. So I'm just trying to get for these opening slides for all of us. Other updates, the course, the Consortium on Addiction Recovery Science, always want to highlight. Today, I want to highlight the fact that there is going to be a national conference on addiction recovery science. It's open to all the stakeholder groups, open to the public, anybody who cares about the science that's being conducted in this space or the science that hopefully will come still in this space. And that is happening on April 24th and 25th. And here's the link so you can find out more details about that. So we hope to see you there. And if you have any questions, certainly reach out. And then here's our usual links. Again, you'll get the links, the slides when we send them out next week. So this is just as an FYI, this is coming and you can peruse through it at your leisure later. Thank you. We will only do the demographic polling questions today because we have really great presentations for pilot studies to discuss. So we're trying to shorten as much as possible in the lead-in here. So kindly fill out these demographics questions. And then once you have answered all these 4 questions, just make sure you click the blue submit button so that it's taken care of. How are we looking, Olivia?
70%.
All right, give it a couple more minutes. Well, not minutes, a little bit more time. All right, do we want to move on to the next slide while we still have it open, or are we close enough to
We just got 80.
Perfect. Here we go. So if you guys want, you can, I think it pops up that you can scroll through the responses too, or does it not do that? Here we go. So as you know, our goal is always to have multi-stakeholder groups here so that we can really inform each other as we are doing science in the addiction recovery space here, especially the peer-delivered recovery support services. And we do have a great mix, which is wonderful. All right, perfect. Moving on to our next slide. We always ground our seminars in learning exactly what it's like to be at an RCC. Today, we are fortunate to have with us Michelle Charbonnet, and she's going to tell us what is going to happen when you walk through the doors of her RCC. Michelle, can you go ahead?
Yes, thank you. So I am director of Mo Network. We're located in St. Louis, Missouri. And so if you walk through the door of our RCC Monday through Friday, you are going to be welcomed in, greeted. You are going to have the opportunity for a cup of coffee, to charge your phone, get on a computer, job search, check emails, whatever you need to do. We have a team of certified peer specialists that you can work one-on-one with, get treatment referrals if that's needed. But throughout the week, we do various activities. We have a free lunch one day. We do free haircuts. We do different types of support groups. So we have an LGBTQ plus support group. We have a female support group. We offer our space to organizations like HA that come in and do meetings. And then we do recovery supportive activities like fun stuff. We do open mic nights, game nights, bonfires, things like that. So what makes us a little bit different than other RCCs is that we're firmly rooted in the principles and practices of harm reduction. So we also run a syringe service program, drug checking program. We do wound care. We give out wound care kits. We do safe sex kits, fentanyl test strips, naloxone distribution. We actually run the naloxone distribution for the whole state for the mailing part of it. And so we also do street outreach. We just got a really pretty ambulance and we go out into the community, take our services out to them. And we really pride ourselves in the fact that we just practice radical love and we show love to everybody that comes in our door, and we make sure that everyone feels really welcome when they're there. And then we connect them with other resources. So we bring in outside organizations like Vivint Healthcare to do free Hep C and HIV testing. We bring in nurses to do the wound care. We've partnered with like local shelters and stuff that come in and offer various resources. So really we try to meet the needs of our participants the best we can. Any need that we see, we try to find a way to meet it.
That's awesome. And yeah, I love many of the little details too, like the charging of your phone. So helpful, right? Game night, I have to ask, board gaming or what kind of gaming?
Yes, like board gaming, card games, all that kind. We have a stack of games that have been donated to us over the years that we pull out, and we do all kinds of different games.
That's awesome. Very, very cool. Thank you so much, Michelle.
Thank you.
All right. If you can move us to the next slide, Olivia. All right, so as I mentioned, we have 4 teams with us today. These 4 teams are all going to be conducting a pilot study within the space of recovery community centers. And the idea of a pilot study is that they are helping answering questions that are preliminary that they then build on for larger projects down the road. So it's an initial look at the particular topic that each one of them chose. So it's not the be-all, end-all study that you'll hear about. It's a preparatory step, and these teams are going to be sharing what they've proposed and what they are funded to do over the next year. And of course, at the end of the year, they're all going to come here. Exactly. Thank you, Sierra. Congratulations to everybody. That can't be overstated. Thank you, Sierra. Each of these teams is going to be spending only 5 minutes to just kind of outline the scope of what they propose to do over the next year. And at the end of the year, they are, of course, coming back into the seminar series to then present what they actually found and what the experience was like and what their next steps are. And in terms of any kind of papers and presentations and otherwise that come from it, you will always hear from us through the email about those things that we are going to share. What we're doing today is to get feedback from all of you. All of you here care deeply about advancing the science on recovery community centers. You all have a different background, a different insight, a different expertise. They're coming to show you briefly in 5 minutes, this is what we want to do, this is what we think is really important, and here are some of the things that we really want input on. And then for 5 minutes, the group will chime in, all of you will say, have you thought about this? I really urge you to consider that. Here's something I've learned that's really important. This is really, you guys are going to be expert consultants to our 4 teams here. I try to keep us on track, so I apologize in advance if I'm ever rude about cutting off conversation after 10 minutes for the teams. We do have the meeting after the meeting from 1 to 1:30. So any questions we don't get to within each project's time, I hope you guys have a chance to stay around for the 30 minutes afterwards, where we don't record, where we discuss more in detail any particular issues that come up. And then I think this is true for all of the teams. If you guys have comments and you can't stay past 1, you can always email them and reach out to them. They'll be excited to hear from you. And you can also email our team and we can forward that as well, whatever you're most comfortable with. So that's the game plan for today. A little bit rapid fire, but let's see how we do. Here are our presenters, and you're going to get to meet each of them in turn. We can go on to the next slide. Oops. And our first presenter, and Rob, is it just you presenting or is Ryan here as well?
Ryan's also in the audience, but I'll be presenting today.
Great. Hi, Ryan, and congrats to you as well. All right, Rob, take it away.
You.
All right, thank you, Bettina. So my name is Rob Bowler. I'm an assistant professor at the Jingping Su College of Public Health at Georgia Southern University. And our pilot project is entitled Recovery Community Centers in Rural Areas, Addressing Unique Challenges to Better Serve Individuals with Opioid Use Disorder. So again, we are from Georgia Southern University, which is located in a rural county and where there is a particular focus on rural health research. Next slide, please. So why study RCCs in rural areas? Well, we know from the literature that problematic substance use patterns and treatment access for substance use disorder are different in rural areas, especially for medications for opioid use disorder or MOUD like methadone or buprenorphine. There are also rural-urban differences in social networks and addiction stigma. In addition, rural areas face unique challenges, especially around social determinants of health, such as employment, education, housing, transportation, and poverty. Rural RCCs are likely to have much larger service areas than their urban counterparts. And conceptually, RCCs are designed to be tailored to the populations they serve and address unique challenges and needs. So therefore, RCCs may function differently in rural areas. Next slide, please. All right, so we are very fortunate that our leaders in Georgia support recovery and recovery support services. In Georgia, we have about 40 RCCs across the state. Most of these are supported with state funds through annual contracts, and about 17 of these, depending on the definition you use, are RCCs that are located in rural counties. So we will take a mixed methods approach, which means that we will be conducting interviews with RCC directors, and we will be administering online surveys with RCC clients. Next slide, please. So we will be doing a pre-interview survey that will be sent to RCC directors that will be participating in the study, and we will be capturing services offered by the RCC, physicality and locality, operations and budget, demographics of the director, and medication attitudes. This is very similar to the organizational study of RCCs in the Northeast that was led by Dr. John Kelly. And in the interviews, we will ask about the challenges that the RCC faces based on rurality, how the RCC has overcome these challenges, perception of clients they serve, especially those on MOUD, the inclusion and services oriented to clients on MOUD, the relationship with other organizations and treatment providers. We'll ask about the RCC delivering services in other settings, policies and other barriers to delivering services, how the RCC is collecting data, and sustainability of the RCC. Next slide, please. For the surveys with RCC clients, this will resemble the study of RCC clients in the Northeast that was led by Dr. John Kelly. So we'll be collecting demographics, clinical characteristics, RCC experience, services utilized at the RCC. Then we'll be measuring some well-being outcomes like recovery capital, social support, psychosocial stress, and quality of life. We will also be assessing medication attitudes using the same scale used by the National Recovery Study and published on by Dr. Brandon Bergman and colleagues. For those who endorse opioids as their primary substance, we will ask specifically about using MOUD, type of MOUD, if a MOUD provider referred them to the RCC, and their experience at the RCC being a person on MOUD. Next slide, please. So what might we find from the results of this pilot study? Well, we think, and the reason we want to do this pilot study is because we think that we'll find that RCC structure and practices will be tailored to the needs of the rural populations that they serve, that viewpoints and practices in RCCs related to MOUD will differ in rural areas, and they may even differ across the rural RCCs that participate in this study. that RCCs may fill the gap of treatment and harm reduction services that is present in rural areas. That rural RCCs will have a unique impact on their communities and the people that they serve, and that this potential impact might include things related to MOUD access and retention, as well as addressing both addiction and MOUD stigma. And lastly, that the impact of RCCs on recovery assets will be different in rural areas and may address dimensions of recovery capital that formal treatment or mutual help organizations do not. Next slide, please. So that was a very brief overview of our pilot study, and we're very excited to get to work. We are interested in any feedback that you may have, especially those who have RCCs that serve rural areas or rural populations. These are some questions to stimulate discussion. So if you are located in one of these areas or serve these populations, does this project resonate with you? So these unique rural challenges, do you feel like your RCC does function differently compared to your urban counterparts? And are we proposing the right questions to ask in the interview and the survey to get at the unique features of rural RCCs? Thank you.
Muted. Thank you, Rob. Questions from you all? Points of clarification or a particular thing that you really think the team should be addressing? Feedback and reactions. So Rob, could you go back to the, oh, thank you for raising your hand. George, go right ahead.
Thanks. Robert, I wonder if there's a way to actually assess, because we know recovery capital is relevant, but even perhaps more significant is the density and the quality of recovery networks. I wonder if there's a way, particularly in rural areas, to determine the degree to which folks are connected to additional resources besides just the RCC, and what role that plays in their ongoing or progressive wellness. Just an idea.
Yeah, I think that that's definitely very important to include in both the interviews and the survey. So asking what other types of services that the RCC clients are involved in. I definitely think that we should add that. And another thing that popped into my head that sort of is on the same vein is, Bettina and her team, their definition of the RCC as being at the heart of the community. And because of these services being either scarce in these rural counties or being very spread out, the RCC, the location of the RCC may be very different too in these rural counties. But thank you for that.
Yeah, and I would, oh,
Go ahead.
sorry. Yeah,
No,
I would go, well, and I might have missed this in your thing, but I'm definitely would be interested in how many people would want to access the services, and their transportation is the issue to getting there.
transportation
Yeah,
is huge.
definitely. We could ask that of RCC clients and sort of hopefully get at that with the interviews. But we're also thinking about how the results from this can be, leveraged into a larger study of looking at people who aren't involved in the RCC, and also looking longitudinally at people involved in RCCs in rural areas and what those outcomes might look like.
Great. We have a question from Dale here. Did you want me to read it, or do you want to just say it?
Okay, Dale says, okay, go ahead.
Yeah, so hi. So I'm actually with a company that we do virtual reality programs, and rural communities is one of the areas we're looking at. So our program is closed. It doesn't require internet access. Is that something, when you talked about looking at resources and assets, in these RCCs, is internet access or access to high-speed broadband, is that part of what you'll be looking at or not?
We certainly want to ask about it, and we've actually developed our methods to take this into account. So we wanted to make sure that the survey would be available to RCC clients regardless of broadband access. It's a little bit different for the interviews, which will be conducted virtually via Zoom. And we from the work we've already done, we're pretty sure that all the RCCs in Georgia have Wi-Fi access. So that shouldn't be an issue. But we definitely want to ask about that too, and how that might impact their access to things like telemedicine or telehealth.
And that's exactly what we're looking at, is the telemedicine and how that can be delivered. Thank you.
So like the questions were up to just follow up on Dale's and George's comment. You're looking at how these RCCs are providing a space in which people can access telehealth if they don't have broadband at their home.
Yeah, we definitely want to ask questions around that.
Exciting. And then in terms of like density, like online groups and how they navigate that space, those kinds of things. Exciting. All right, a last question. We are at the 10-minute mark for this team. Do we have other questions? And remember, there's still the time after all the presentations to ask more questions. All right, let us move on. Thank you all for the cool questions and thank you for presenting. All right, Angela and Craig, take it away for us.
Hi, well, I'm so excited to be here. I am Angela Hegeman, Research Assistant Professor at East Tennessee State University and co-director of the ETSU Addiction Science Center. My colleague Craig is here. Craig, introduce yourself.
Sure. Yes, I'm Craig Henderson. I'm a professor of psychology at Sam Houston State University, and I direct our PhD program in clinical psychology. And really grateful for groups like this, because it's groups like this that brought Angela and I together, and we're really excited to share some ideas of what we'd like to do moving forward.
Exactly. All right, so we'll just dive right in. We'll go to the next slide. Thank you. So just sort of setting the stage for why we were interested in this topic. We know that RCCs, are sort of thought of as the new kid on the block. And maybe as the new kid on the block, maybe they're not as well understood as other options or recovery supports in the community. We know that they're operated by a combination of volunteers, certified peers, and others with lived experience. And in my experience, when I go to an RCC, they have some similar themes and a similar tone, but they're all sort of very different too, and they look different in rural versus urban environments. And the staffing patterns look a little different across different RCCs. We also know that they vary greatly across subregions, or we assume that they will vary greatly across U.S. subregions. And we know that due to the nature of an RCC being a low threshold setting in a community, ready with an open door for folks to walk in, that clients, patients, people may walk in and present with challenging comorbid health conditions, physical health conditions, mental health conditions, and other crises or challenges. So we think that if we better understand that workforce, those that are providing staffing at the RCCs, their perceived confidence and competence in dealing with some of these complicated health conditions, that we might contribute to the scientific literature and also provide the kind of support to sustain this vital workforce long-term. Next slide. And so the first aim is we are also presenting a mixed methods research design. So it was great to hear that from Dr. Bowler. And we're looking to assess RCC staff qualifications, sort of their employment status, their training and certifications, also their mental health and recovery status, and their objective and subjective experiences pertaining to their job satisfaction and their self-efficacy for service delivery, meaning sort of how do they feel about, how confident do they feel in performing their tasks and maybe addressing some of these comorbid, complicated health situations that might come through the door. So in this design, our sample frame will be the list of recovery community centers that the Recovery Research Institute already has, and also SAMHSA has a list of RCCs and RCOs across the United States. There may be other, we might ask that at the end, other opportunities to look at other lists, and we're going to create a national sample of RCCs, stratify that sample by the 5 US subregions, and then also further stratify that within the subregion by the RUCA code, the rural coding frame. It's sort of a way to identify which counties are rural and which are not. And then each RCC, we're going to recruit 10 RCCs. Each RCC will receive $500 for their RCC to participate in assistance with recruiting 6 to 8 staff for a one-time virtual focus group. Each person participating will receive a $25 incentive, and then also will be disseminating a web-based survey to all paid and volunteer staff. Dr. Henderson might talk a little bit about some of those metrics that we're looking to collect.
All right, let's move on to the next slide. Thank you, Angela. So what we're wanting to do secondarily is identify the most common services provided, and both at the RCC and as well get a sense of what's happening in this regional recovery ecosystem. I really like this terminology, really resonated with Angela and I. And George, appreciate your question earlier about this, and we're hoping to get at an understanding of what this ecosystem really looks like. We want to look at the role RCCs play in facilitating recovery support, the linkages to care within the ecosystem. So in terms of connections with community agencies, we're going to be using some, well, drawing from some work that Dr. Hageman has done, looking at what peer recovery support service specialists, what kind of activities they're engaging in what settings. We want to hone specifically here on what individuals, volunteers, employees in RCCs are doing. What activities are they engaging in? What kinds of referral processes and linkages are they making use of? Would like to get into some of the employment and organizational outcomes that I'll discuss a little bit more in the next slide. We want to look at variation across geographic region and population density. And very interested in the work that Rob, you just presented, and commonalities here, both in terms of an interest in rural locations and how those might differ from more densely populated areas, and the mixed methods design, because we'll, as Dr. Hageman mentioned, we'll be collecting qualitative data from focus groups to get a richer understanding of those linkages and referral networks, as well as the participants' perceptions of their roles in this. All right, next slide, please. So thirdly, we're going to look at correlations between RCC staff characteristics. An example here would be employment status. Are they volunteer? Are they hired? Other examples could be background and training credentials, and employment outcomes. We're also looking to see if these correlations are in turn influenced by the recovery capital of these staff members. So in terms of the outcome domains, we've mentioned self-efficacy and service delivery, but we also want to get into job satisfaction, job stress, if folks are feeling burned out with their work, their own mental health, and their recovery history and recovery capital, and how these are influenced both by background and credentials, and how those associations may differ depending on the individuals' recovery histories and recovery capital. All right, next slide, please. All right, so we very much value your input and thank you already for what you've provided. I made a couple notes on things that weren't even directed to us because they're great suggestions, so thank you. So I mean, we would welcome any feedback, but some questions to maybe generate some discussion. What do you think about how we're planning on recruiting and sampling? In particular, are there lists of RCCs we should be aware of? So Dr. Hagman mentioned those that are kept by this group in particular. Also, am grateful to John at the Voices and sorry, tongue got tied there. Faces and Voices of Recovery and the active lists they are taking. So feedback on sampling and recruitment. I'd like thoughts on domains we're assessing. Are we looking at this in an overly pessimistic way? And are these domains the ones that seem most relevant? This is kind of a technical question, but it ties into another study. We proposed a measure of mental health called the Depression, Anxiety, and Stress Scales, but I see another project is using PHQ-9 and GAD-7. These are brief 9-question measure of depression, 7 questions on anxiety. And should we look at maybe using those measures to have some consistency across these projects? And any other thoughts or questions you might have for us. So thank you very much.
Perfect. Thank you, Angela and Craig. Questions for you guys. We had a question about recovery capital that Ben already fielded for us. Thank you, Ben. Other questions, or do you want more feedback? Actually, Craig and Angela, when you talk about recovery capital, are you assessing it with the BARC 10? And do you want to mention what that specifically entails? Or are you also looking at other ways of capturing recovery capital?
Yeah, thank you, Bettina, and whomever, I believe Ben maybe who posed the question. We are looking at the BARC 10. The BARC 10 is, it's very convenient because it's 10 items, and the research holds up that it measures what it's supposed to well. We would look into other measures of recovery capital, but at the same time, we want to balance that with participant burden as well. We don't want to we're assessing a lot of different domains and don't want to overload any particular, individual, or maybe put a barrier to them participating in the study because they, it's just too much for them to do. So I think we want to balance both of those things.
Great. And Sandy, did you want to say your question, or shall I read it for you? So Sandy had a great point about looking at the peer workers and their use of medications before they became a person delivering support to others. Is that something you guys had on your radar already?
That is excellent, Sandy. Thank you so much. Yes, I think we will want to do that. I believe we did devote some space to that in the application. At least I hope we did. But yeah, that's certainly a relevant aspect we would want to collect. Angela, any I don't want to hog the conversation here. Anything you would add to these?
No, you're great at co-presenting and sharing the stage with me. I think that it is definitely a construct I would like to add to the interview guide for the focus group, sort of that discussion around MAT, and if you came from an abstinence-based background, did that shift, or how does that look when you're working with patients in the RC, not patients, clients, customers, people that walk through the door at the RCC. There is, my team here is working on a stigma against MAT scale that we've been using, but it's quite a long scale. And I don't think it would be appropriate for our quantitative instrument, but we might find a way to get at that through our survey in addition to the focus group, but it is definitely on our radar and I think an important topic. Thank you.
Angela, remind me, we do have a scale that a colleague developed, which I think might be shorter for exactly that purpose. So remind me to
Cool.
put that up there. We do have to move on in a moment. I just wanted to go back to George's comment from earlier. Access for folks with disability, to what degree that's integrated into the RCC setting in various places. I know that in at least the research I was involved in, we have absolutely neglected that. And that's a great note for future work, to take note of that and to dive into that. So thank you, George, for that. All right, then for remaining questions, we'll hold those for after all the presenters have gone. So if we can move to the next slide here, we will have Joe and John present. Stage is all yours.
Thank you, Bettina. Today, John Picard and I will be presenting an overview of our pilot project, the exploratory analysis of the recovery data platform, to uncover group associations between engagement and outcomes in RCC participants, where John and I are principal investigators and Bettina Hopner is a co-investigator on this project. We're out of Harvard Medical School, Massachusetts General Hospital, and Pace and Voice of Recovery, where Pace and Voice of Recovery has built and disseminated the recovery data platform, in which John can further go into more details on.
Thanks, Joe. Next slide, please. So my name is John Picard. I'm the IT manager at Faces and Voices of Recovery. My focus here is on the recovery data platform. I'd first like to give a absolute thank you to Mo Network. RCCs like Mo Network, especially focusing on harm reduction services, is crucial to the recovery movement that's going on today. So I just wanted to give a thank you and a shout out. So a little background and significance of the pilot study. So RCCs across the country are providing a plethora of services and engagements to support the recovery needs of individuals and of communities, including multiple pathways like medicated assisted recovery. But it's a challenge to maintain that engagement with people in recovery for various reasons. But through peer-driven connection, like recovery coaches, peer recovery support specialists, different activities that occur at recovery community centers, just a safe space to hang out at. There's a lot of exploratory data that can be collected on engagement and outcomes, and analysis can be done on that to see what's working and who is it working for and when. Next slide, please. So the recovery data platform is a cloud-based encrypted data platform that is utilized by hundreds of RCCs across the country. There's quite a number of unique participants inside of RDP, 139,000 and counting, with a lot of them having multiple engagements. So greater than 5 engagements, or at least logged, recorded engagements. And we have over 1.3 million entries, from recovery coaching to telephone recovery support and activities and everything else. So the recovery data platform really assists RCCs and RCOs with individual and organizational data analytics of recovery, from collecting things as basic as demographics like race and gender, to getting into more outcomes like assessments and recovery planning and referral tracking, and just activity logs such as different recovery meetings and social events. Next slide. So the man that you see on your screen there, Phil Rutherford, wanted to give a shout out to him. He's the former COO of Faces and Voices of Recovery, and he was instrumental in getting RDP, Recovery Data Platform, off the ground back in 2016, 2017. It was his vision. So I wanted to give a shout out to Phil. And if you want to learn more about RDP and what it does, take a look at the Recovery Seminar number 27. We made a presentation back in September. So one of the things that we want to do is communicate to public health, community health, policymakers, funding agencies, the effectiveness of recovery community centers. There's a lot of linkages that RCCs have from different health partners, emergency departments, recovery residences, counseling services, food banks. So we really want to inform those individuals of using this policy study. So I'll turn it over to Joe to tell us what we're actually going to look at.
Thank you, John. Next slide. So some overarching questions and goals of the pilot study are to improve our understanding of RCC utilization by different groups of people, spanning demographics and other dimensions, to characterize RCC member engagement patterns over time, to explore member variable engagement activity associated with improved outcomes, to test informative value of baseline assessments, such as less than 30 days from intake, on engagement activity and utilization patterns, patterns that include duration of membership, frequency of engagement, and test the interaction of MOUD history with group variables on engagement and outcomes. Next slide. And we'll test those questions across the following aims. Specific aim 1, we'll quantitate and statistically describe RCC engagement across member characteristics in time. Really, specific aim 1 is about really doing a deep dive into and get to how people are using RCCs, and we wanted to define engagement as every validated interaction between the RCC and the member. And specific aim 2, once we have those engagement profiles, understand how people are using it, see how that associates with outcomes. So we want to explore the relationship between RC engagement and outcome measures across member characteristics that we've established in time variable. Next slide. And in those aims, we're looking at the following measures and variables. So group variables include basic demographics, age, race, ethnicity, gender, substance use history, including any prior use of medications, and other dimensions, including referral types and other things that we'll look at. In the RDP, we have pre-specified fields of engagement that are group attendance, recovery coaching, supplies, materials, and goods, such as harm reduction supplies that are delivered or received, telephonic recovery support, transportation log, and volunteer logs. And we're looking at 6 assessments that the RDP contains that span recovery capital, including BART 10 and SHORE, mental health questionnaires, PHQ-9 and GAD-7. And recovery data platform has engagement scale data that they've broken down into 3 sub-domains, including craving rating scale, outcome rating scale, and relationship rating scale. And next slide. And so we're really excited to be doing it, casting a broad net and a deep dive into recovery data platform to gain meaningful insights and help kind of, fulfill that initial vision that Phil Rutherford has set forth and challenged the field with, so that we can improve, help people support their recovery. And the questions are open-ended to what comes to mind. And we'd love to learn and hear about what you have in your questions.
Wonderful. Thank you, Joe and John. Questions from you all. And while people are thinking about questions, I just wanted to note 2 things. I love that, the PHQ-9 and GAD-7 is something that Angela and Craig also talked about using. So it's nice to see that we are using some of the same measures across different settings, which is great. And the other thing I wanted to highlight is that Joe and John, you basically connected because of that seminar that we had in September. That's how you guys got in a conversation to do this study. So for everybody else here in the room, if there are seminars in the past or in the future where you see something that intrigues you and you wish you could get involved or find connections to do that kind of research, do let us know. We always hope to make those connections and help support that. Susanna, you want to go right ahead? I see you have a question here.
Yes. Hi. I just wanted to check briefly, for the people that actually don't engage, how do you get the outcome data? Do they have a portal where they report these outcomes outside of their RCC attendance, or is it going to be massively missing if they don't engage, they also don't assess? And that's, I don't know, that seems problematic, but you might have already thought of that.
Well, that's Susanna, that's a interesting point, is that if they don't engage, then we can't really get data on them. But yeah, it's up to the RCC what data they collect as well. So that's for those people who do not engage much, that's going to be part of what we're going to be looking at. I believe the deep dive is how people engage. Yeah.
Yeah, just to add to that, so we'll be looking at the strengths and weaknesses of the data and consistency and reliability and validity when we do these things. But it's the scale. We're hoping that the scale is to capture a signal. That yes, there'll be the areas that we can capture data. There's missing data in these types of things, but the numbers will allow us to get at the sample size that we need for meaningful interpretation.
And the other thing is it is a pilot project, right? So our idea is really to dive down. That's very, it's time for us to really see what is and what isn't there and what's missing and what's systematically missing. Those kinds of questions is what we're going to be able to spend some time on and to understand it. And then if they're, to see what answers can we answer given the data at hand and knowing the limitations, because it's real life collected data, not in a research setting. This is real life clinical data collected in the real world settings. Sheila and George. Oh, I couldn't quite catch both of you. Sheila, do you want to go ahead with your question or shall we read it out for you?
Sure. It's not really a question. I just wanted to make a point. I think it would be important for all projects to incorporate demographics about participants who are housed versus unhoused, especially in urban areas, because we know a lot of people with SUD or other, opiate use disorders, et cetera. A lot of them are also unstably housed, and we might see differences in these outcome measures as a result.
Great point. All right, I see George commented on liking that the outcome rating scale and relationship rating scales are there. And I think the relationship rating scale, you might want to just share that too with Angela and Craig, since they're talking about the relationships that the peer workforce also has. That might also be of interest for you all to see what those questions are. Other thoughts, feedback before we move on to the next one?
Yeah, I just want to let Sheila know that we do, or RCCs can collect housing status from being either housed or unhoused, or so that is one of the data points that is collected inside of RDP. So, and it's something that I cherish as well in looking at that data.
Great. All right, then let's move on to our last presenter for the day. Ben, it's all yours.
All right, thanks, Bettina. Hi, everyone. Can you hear me?
Yes, we can.
Hey, good to see you all and nice to be here. My name is Ben Thompson. I am a postdoctoral research fellow at the Recovery Research Institute at Mass General, and presenting this pilot project entitled Investigating the Impact of Recovery Narratives Among Affiliates of Recovery Community Centers. Oh, you're a step ahead of me. Good job, Olivia. All right, so we all know that the lifeblood of the Recovery Community Center is the therapeutic modality of peer support. And of course, the linchpin of the peer support model is the lived experience of the peer. What often gets overlooked, however, is that the primary vehicle by which that lived experience is shared from peer to peer is storytelling. Memories about experiences in and out of recovery are related by way of stories that may be broad, sweeping generalizations about what happened, what it was like, what happened, and what it's like now, or they could be in reference to specific events, just about a day in the life of somebody in recovery. But the point is that they're all stories. And a major element of the recovery process is sharing these stories, both by telling and by listening. So recovery narratives really are the mechanism underlying the peer support model of RCCs. Next slide, please. But the crucial thing to bear in mind is that such stories are not just about transmitting information or wisdom. Anytime we tell a personal story to somebody, we're actually reinforcing the lens through which we view ourselves in the world. And that actually has downstream effects on what comes next in the story. So we already know from a wide body of evidence outside the realm of substance use and recovery research that how people talk about and narrate their experiences of illness influences their journeys back to health. In other words, it's not just that storytelling about recovery reflects the experience or the pathway, but actually recovery narratives predict recovery outcomes. In the context of an environment where the transmission of lived experience is of paramount importance, this is especially significant. More relevantly, in a context where there's a premium on embracing an all pathways approach to recovery, this has further implications because it suggests that some ways of talking about recovery experiences may actually be associated with better outcomes. And this is what we want to investigate. Ultimately, next slide, please. Ultimately, we want to understand the role that RCCs may play in shaping the recovery narratives of their participants, thereby potentially influencing the unique trajectory of recovery outcomes. So for this study, we're going to employ a mixed method study design to evaluate the linkage between recovery narrative and recovery outcome. Good job. So we're going to recruit 30 participants who are seeking or are in recovery from SUDs, substance use disorders, and are currently enrolled in a larger parent study, which is being run by Dr. John Kelly, from which we'll be drawing survey data related to our aims. We're going to have 2 subsamples. The first subsample is going to comprise 20 participants who have been involved with RCCs in the past year. And the control group will comprise 10 participants who have no RCC involvement over the past year. Next slide, please. We're going to collect all of our qualitative data through video interviews, which will be audio recorded and transcribed via a software called In Vivo. And next slide, please. So to collect the qualitative data, we're actually going to be using an approach called the life story interview. And rather than collect the sweeping generalizations of somebody's experience in recovery, we're going to collect 3 main scripts, which are recovery-related low points, recovery-related turning points, and recovery-related high points. And we're going to collect 2 instances of each 3 scripts. So for 30 participants, this is 180 scripts that we'll then have to code. But they're brief scripts, and that makes it a little bit more feasible. We're going to code them for 2 primary indices of narration, which are emotional tone. And to give you a sense of tone, we're talking about valence. A redemptive tone would be where the experience goes from bad to good, and a contamination tone would be where it goes from good to bad. We're also going to be looking at various motivational themes throughout these scripts. So in other words, why did they have relevance? What was their value to each individual? And we'll be looking for themes such as personal agency, communion or connection, Hedonia, that's the desire to feel better or to feel good, and eudaimonia, which is personal growth related motivations. Next slide, please. So as a proxy for how recovery narratives may mediate the relationship between recovery pathways and recovery outcomes, we're going to stratify the RCC subsample according to recovery pathway, basically in terms of medication-based and medication-free approaches. And this is going to allow us to begin to get a sense for how recovery pathways, which are expressed through recovery narratives, may actually influence downstream recovery outcomes. And we're going to compare the association between the narrative features, emotional tone, motivational theme, of all of these recovery stories with the recovery outcomes. Some of the outcome measures that we're going to be utilizing here are listed, for example, substance use, psychological well-being, and recovery capital. And then finally, in our last aim, to begin to get a sense of the role that the RCC actually may play in shaping how recovery experiences are interpreted and thereby narrated, and therefore to get a sense of the relative impact the RCC may have in determining recovery outcomes. We're going to compare the association between the narrative features of recovery stories and recovery outcomes from among the RCC involved and non-RCC involved participants. We expect to find that the storytelling ecology of an RCC will ultimately play a role in shaping the way that people think about and talk about their recovery experiences, which is going to affect recovery outcome. We plan to disseminate the findings from this study through the Recovery Research Institute website, as well as the Health Through Flourishing website. We plan to have multiple publications, which will be disseminated in relevant journals and at conferences. Most importantly, though, this is going to lead to some novel qualitative insights about the mechanisms by which RCCs are purported to have their salutary effect. And that's going to set the stage for future grant proposals and some ongoing studies. So in conclusion, I would love to hear any thoughts that any of you have on methodology. In particular, I know that there are a lot of affiliates of recovery community centers on the call today. And so I'd love to know whether there are any considerations you may have on other aspects of recovery narratives that may be worth exploring.
Wonderful. Thank you so much, Ben. Questions from you all? And while they are thinking, can I just say, Ben, that you had the most amazing artwork? I love that in all of your slides.
If you're not using AI for your slide presentations.
Duly noted. Duly noted. Craig, go right ahead.
It's so funny that you mentioned that, Bettina, and I'm sorry for the non-substantive question. Mine was, and Angela and I were chatting back channel about this. It's like, Ben, where did you get your slides? Those are awesome.
Oh, there's an app called Dolly. It's just the DALLE, and
okay.
It's mind-blowing and terrifying.
Excellent.
All right. Awesome. Thank you. And love the project too. Thank you for permitting the question there.
For sure. Olivia, can you take a note that we include that link in our email for folks? Wonderful. Other questions from folks? Go ahead, Joe.
Yeah, Ben, the slides as well. Half my time was just trying to come up with my design for the slide, and just look amazing. And so it's really interesting project. It's inspiring. For lack of a better word, but the institutional influence that is projected onto those seeking recovery is and how that affects their outcome. I think that there used to be things that have been thrown around, like, a person might be in a treatment center and they might say, only 3 of you are going to be here a year from now out of 100, 3%. I mean, I just don't know what kind of like self-fulfilling prophecies or projections that, how that supports people looking for a new way to live. So, that impression or how institutions can impress a positive outlook or outcome onto their participants or people seeking treatment or recovery is very interesting. So I think it's very inspiring work.
Thanks, Joe.
And in terms of how you plan to implement it, I just need to learn more myself. It seems interesting that how you will be able to quantitate these stories and narratives, and I guess what are your thoughts on? So there will be themes that emerge, right? So what are your thoughts on thematic saturation and how you'll get there, or what it'll take? Might be a relevant experimental question.
That is a good question. That's something I'm going to have to take into account. This is not only the direction that I believe in, a field that I think is kind of worth pursuing in its own right, but it also represents a shift in my direction methodologically. And so I'm kind of building the airplane as I fly, so to speak. So any input like that, these are all great questions for me.
And there's a question in the chat. oh, I just need to scroll up again, about, where was it? Julie is asking if a style of storytelling is born out of a certain pathway. Does the culture of a pathway influence the style of storytelling? Is that going to be something you'll be looking at, Ben?
That's exactly what I'll be looking at. Yeah, it's the story that is told is emblematic. It's iconic of the pathway. That much is almost self-evident. When somebody's telling a story, you just take for granted that they're describing their experience, but the experience corresponds with the pathway. But what we fail to account for is the way in which there's like a top-down effect. So it's not just that you're representing it, but then it also will subsequently shape what comes next in the experience and in the pathway. So there's this dynamic and iterative process of participating in the pathway, which the narration piece plays a critical role in.
Perfect. I see a couple more questions coming in. I just did want to let people know it is 1 o'clock and some of you may have to go, and we'll get to Dale and Cherise coming in a moment. But I just wanted to say congratulations again to all of our teams. We are very excited about the research you'll be doing over the next year, and please shout out for help and feedback from everybody. And we're very excited to have you back in a year from now with results. And thank you all for being here, for posing questions, for sharing thoughts, for shaping this. And as things come up beyond the seminar, do reach out, do share your thoughts. This is how we build the science of recovery community centers together. So thank you guys all for being here. Really appreciate it.
And Bettina, if I may, thank you so much for your support for these projects and for just some great reviews, and so much appreciate you all making this funding available and supporting us with that work.
Thanks, Greg. And of course, NIDA, who's funding it all. We do have a great review committee. Several of them are here today who've provided the feedback. It's a team effort as everything else. Thank you. All right, we can stop the recording, and we do have an extra half hour